Hello and welcome to Note to File, a clinical research podcast.
A collection of interviews, candid commentary, and general nonsense for the clinical research community.
Check us out at notetofilepodcast.com.
And now, without further ado, on to the show.
Hey guys, it is April 14th and another Note to File. It's Tuesday. How's it going, Denali?
Yeah, it's going pretty good. It's been a busy week. It's been good. How about you?
Not too shabby. You've been, at a conference?
Yeah. There was actually in Madison, ACCA, CCAF conference.
Too many letters.
Because we need more acronyms. No, it's, oh God. Okay, it is Association.
I don't remember it. Too many letters.
I got it. Association of Cancer Center Administrators. Cancer Center Administrator Forum?
Why does it say Cancer Administrators twice?
I don't know. The association is ACCA and the conference is CCAF. So it's AACA is CCAF.
No, we got to do better.
But it's a collection of all of the administrative directors, their teams of the NCI designated cancer centers who come together and talk about a lot of things, but like a lot of their concerns.
Administrating?
The administration of the cancer centers. So like, it's a lot of like the CCSG, like cancer center support grants, and like that's how you become a designated center. And then there's all of these like rules, regulations around like what you have to maintain that designation and get new designations and grants and investigators and publications. It all kind of like ties together to basically prove that they're doing what they said they're doing. So we were there, it was interesting. And it's a conference I've been to. Actually, the last time I was at this conference was March of 2020. It was like the last conference I went to before COVID. And it was like in San Francisco. And it was before COVID had really like hit the US. It was like coming over from out of overseas. And there was a cruise ship that was coming into Bay as like we were flying out. And that was like one of the first like big.
Yeah.
And they like put it in like I remember reading like news stories about it that morning. They're having it dock in like the industrial bays and not like the actual like cruise center perspectives. And so it was like, it's an interesting, and it was weird concept where like, that was the last time I was there. But anyway, so it's a group of like, from a technology perspective, it's fascinating because they're much more focused on like the administrative side of things, less the operations.
Yeah, I was going to ask like how in tune are they with like the, the software that, maybe their people are using, but
or just like even clinical trial operations, which is interesting.
Yeah.
Because the cancer center itself isn't just about clinical trials. Like there's other things like, no, I mean, like a lot of it is research, right? Like that's a lot of what oncology is, but they're looking at like the holistic administration. And so they're looking at across like registry information they're required to keep and all of this stuff. But like, I won't name particular organizations, but there was ones where we were talking to the administrative director of a large designated cancer center, and they didn't even know that one of their like key counterparts on the clinical operations side had like left a couple months ago. So like there's very disconnected as far as like they're administrating and running the cancer center from that. Again, there's the medical director of the cancer center and the administrative director. They know it's important. They know the systems they like by name, but they couldn't tell you much else besides that, which again is not their day to day. Like that's not what they're focusing on, but the disconnect was interesting to me. And it shouldn't be surprising, but it's.
No, I mean, we talked about it before, like even in systems or whatever you want to call them, academic medical centers, hospitals. I mean, really research is generally sort of even within those where they're, generally touted as being like a big deal. It's very often not recognized that well. Again, I told you I worked in a hospital where they had research for 20 years, and we'd walk in to see a patient and be like, "We're here with research." I'm like, "What? What is that? We don't have research." I'm like, "Yeah, okay. You know what?
Yeah, you do.
Doesn't matter."
Yeah,
just scoot over.
But it's interesting to me because like these are the folks who are managing the grants and the publications, all the things that are coming out of the research or that are funding the research if it's not industry specific, right? Like all of the federal grants that you get to run IITs and such. And so it's critical to what they're doing. I'm like, yeah, you have to divide and conquer, I guess, but it's just like, no wonder we're so inefficient with research, because I guess it's scaling for anything. You get big enough and like you have to specialize at some level, but then you specialize and you silo too much. And
and I think start to suffer from their own success in a way. Like the more ability you have to sort of scale and grow, the more silo thing just sort of seems to happen, like as a byproduct. I'm sure that's not the way it has to be, but it does seem to happen time and time again.
Yeah, consistently. So, but it was good. I mean, I think it is a fun conference because it's a group of really passionate people who care about what they're doing. And I think that's, I don't know, I'd rather that than go to conferences where people are like, yeah, I'm just kind of doing what I'm doing. Like, I'm here for the paycheck. Like, these are people who are really passionate about the work they're doing, the programs they work in. And so it's cool to be around those types of folks. So it was good. It's literally just wrapping up now. Was there yesterday and had a fun little happy hour that overlooked the state capitol, which was a fun little view. So that was good.
Very fancy.
It was super fancy, but it was good. It was a good time. It was a good time to connect with folks. But again, it just always strikes me, especially when you start getting to those like large academic groups, the separation. I also think that was the other topic we had that we talked a lot about with folks is, and again, this has been since I've been working with this type of group in the space, but like the disconnect between cancer centers and the rest of the organizations they work with. So they have like their CCSG, and then you have the CTSA or CTSIs that get the CTSA's awards, or like the non-oncology research, and how there's just such like a tension between the two groups.
Why is that? Why would that be?
It's interesting. It's so common. Like it's, I mean, I remember hearing this over and over again. You have groups who the cancer center is so defined. They have the CCSG award that they get, and it's really definitive of what they need to do, how they need to do it. Then they're generally much more like regimented and centralized in what they're doing in the cancer centers, because they have to be for their designations and their grants. And then outside of that, it's much looser. And there's much less centralization across. Is neurology doing the same thing as cardiology, doing the same thing as dermatology? And unless you have a really strong CTSI or, with a CTO, like you might not be as centralized. And so then they all try to do some level of, hey, we're all doing this, we should standardize. And so it's like everyone feels like they're not getting what they want. And oftentimes it's the cancer center space has a very particular way they want to do things, and everyone else wants more flexibility. And it becomes sort of this like push and pull of like who gets to make the decisions on what systems we're using, how we handle it. Which is interesting.
Yeah, that's fair. And given in my sort of, it's been a while since I worked in academia, but it almost like the oncology cancer center did it was like its own thing. And then there was like everyone else, and everyone else was not, there was no consistency. There was no like central organizing faction of any kind. It was just kind of like each department was like, well, good luck. Each department figure it all out on your own.
I find that but then eventually they get to like a certain nexus point at their organization where someone's like, hey, we're all doing this. We should all centralize and come up with some efficiencies for all doing it the same way. The other piece is also like from just a reporting standpoint, like as an organization to understand how we're doing research, where we're doing well, where we're not, how our finances are. Like you want kind of a single view. And if you're that separated, I can't imagine you have that of your institution.
Yeah.
But it's exceedingly common.
Well, fair enough.
So anyway, it was a good conference, but it was busy. It's a busy way to start the week. I feel like I always struggle with early week conferences because then I leave and I'm like, okay, it's weekend, right? Like I'm done. It's like, oh no, we still have 3 or 4 work days left.
starting on a Monday is
starting on a Sunday.
Tough. Or Sunday even tougher.
So it's I always struggle with that. Oh well. And it's weird being at a conference like here, because then you also like you still have your kids, like you still have like your normal life too, or you can't just like get into conference mode and like go. And you're like,
sure,
babysitter, gotta go back home.
Yeah.
So
that's a whole different swing on things. Yeah. So just a weird start to the week with the.
What about your week?
Yeah, well, I mean, it's Tuesday. I've had, I don't know, it's been a fairly quiet week. I've been dealing with, first of all, guys, if you're in the comments, I see there's people watching. Feel free to throw in whatever you want. We'll talk about whatever. These last few episodes have been fairly unstructured, which has actually been nice because people have brought some things to the table to make the conversation fun. So feel free to do that or not. Don't care. I'm not the boss of you.
What day is it today? We didn't even do that this morning.
Oh yeah, today is today is International Moment of Laughter Day, which is great. I like a good laugh. Today is National Donate a Book Day.
Okay.
Today is National Look Up at the Sky Day, which I enjoy doing. Seems like a weird thing to dedicate.
Why do you need a day for that? Is there any? That's the one I'm most. I'll stop by a little library. I'll drop a book off. Great. I'll have a giggle.
Yeah,
awesome.
Yeah. I'll have a giggle.
See, just did. We're done. Check. Box checked.
Did it.
What is Look Up at the Sky? What is Look Up at the Sky Day? Like,
well, although the history is a little vague, some believe it started in honor of Jack Borden, a former Boston newsman who quit his day job after looking at the sky for what he considered to be the first time. He wanted others to see what he saw that day and founded For Spacious Skies, a nonprofit in the 1980s. Focuses on teaching children and adults to live in the moment rather than passing through life without noticing nature's beauty.
Well, I really like that.
Yeah, I mean, me too. So there you go. So don't talk shit about National Look at the Sky Day until you know the history.
Fair. I just would have named it something different.
I
also did not think that's where the story was going. I thought it was going to be like a weatherman who was looking at the sky and being like, it's raining out today.
And today is also International Be Kind to Lawyers Day, as well as National Ex-Spouse Day.
Put those two together.
Yeah, I mean, those seem to, they have to be together, really.
Right, they put them together.
There you go.
Well, that's a funny one.
Those are the days for today. Yeah, I mean, my week's been fairly quiet. I have a sponsor who wants us to send them screenshots of our eSource so that they can distribute them for their team to look at, which is completely mind-boggling to me.
For what?
So
is it trying to do source data like verification? Are they just
I
like
think
how
so.
you
so
do
like,
something? Like what are they doing?
This is a small sponsor, and they did a thing where it's essentially like, look, enroll your first 5 patients, we'll review it. And so we did that. And yeah, there were some, look, like any study in the beginning, there were some changes we needed to make to source. Yeah. We made them fairly easy to do. Now they're trying to sort of, I don't know. I had this conversation with somebody recently that like people really have a problem if like your eSource doesn't just like perfectly match like, box for box against what's in the EDC.
Okay.
Which is not necessary. It's just not. It doesn't have to be a perfect one-to-one, page by page. Like
you just need the data.
It makes it easier.
The data fields need to match. That's all.
Yeah, I've worked and seen places where they will literally like put a medical record and be like, here's the source.
Yeah.
I'm not going to put it in some boxes to then put it in other boxes. Like you find it, it's in here, or maybe it's highlighted. And, some of that work's not quite spoon-fed to a CRA who's their job to source data verify. It's not our job to make their job easier. Right. Obviously, we want it to be easy, but
right.
Nonetheless, dealing with that, which to me seems absurd, and then they want to have the ability to.
Is there compliance concerns? Like you shouldn't be sending screenshots of that shit, right? Like over email. Like what?
Again, I don't know. I'm going to be like, you have access to it. If you want to take a screenshot of it, then that's on you, not me. Like don't like make me do it. If you open it and you do a screenshot, then, knock yourself out. But again, just some of the like weird stuff we run into.
So do you think that is a person problem, i.e. it's the CRA, it's the organization, or it's like a process problem where they're like, this is how we do this?
No, I think it's probably a small team that's fairly green who doesn't quite know what they're looking at or what they're doing. And
Got it.
we try to be cool and like work out, through these things. But I'm like, dude. And then they want to have continual. This is where it gets interesting. I think when you're talking about like the future too of clinical trials, like they want to have continual access to monitoring, like of our eSource.
Why?
I don't know exactly. I guess they want to be able to look at it at any given time. They want to be able to make sure everything's going correctly. It's one of those things where the problem, look, conceptually, I like the idea of like being able to get, I'd love it if like each patient were like reviewed in the time that they were being done. Everything's clean. You could be done immediately instead of a monitor comes on site in 6 weeks and you've got 15 patients worth of stuff to try to clean up. But the downside of that is there's like potentially never ending queries, never ending access. And I'll be really honest too, like most sites charge based off of monitoring visits because you've got to give your time to that CRA and you're not doing
to their queries and help them through the process. Yeah.
So then, it gets to be again, like a real conundrum. They're like, well, you can either do 5 at a time and wait for us to monitor, or, if you had continual access to monitoring. I'm like, dude, both of those options kind of blow, frankly. I don't want either of those things to happen. So we'll see. Just another fun caveat.
I wonder, like, do you budget then for that differently? Like, could you do like a protocol level fee for like, great, continual monitoring? If you're going to do that, this is the charge then for that.
Yeah, I would strongly, I would consider that. This is something that literally just came up today and we haven't even really talked about it with my team yet, but I'm like, okay, if a monitor visit is $500, I'll tell you what, I'll give you a 40% discount. We'll charge you, instead of $2,500 a week, we'll give you $1,500 a week. You just pay us and it's open all the time. I don't know. We'll see how it all turns out. But like, the worry I have, I've talked about this before with all of this, and this study I'm not that worried. It's fairly limited in its data collection. It's not anything crazy, but we start hitting a world where we are using wearables, ePROs. There's a constant stream of data coming to sites and being monitored or, otherwise looked over constantly. Like, I don't know how I don't know how sites are not going to get inundated with constant barrage of more data. Then you've got AI. So like, again, you're not waiting. It's all happening in real time. That's worrisome to me because, at what point is it just, you're drowning in data? Most of it's not clinically relevant necessarily, but, if a PI has to have oversight and this data is being generated all the time, then how do you sort of, balance those two things?
Yeah. Or is it to the point where you're going to be inundated, so you just have to budget for it appropriately to understand this is going to mean X change in time and effort, so it's going to cost more.
I saw something over the weekend. I was reading. I try not to open LinkedIn on the weekends, but occasionally I do. And there was a post from, I don't know who made the posts, but it was about kind of like clinical trials. It needs to be easier for sites or whatever. And I think it was Scott Witt, who I know runs a site. I think he's in North Carolina. He responded in something that like I actually kind of am beginning to agree with more and more, which is like, no, like the difficulty and complexity is like a feature of a clinical trial, not a bug. And instead of, because it creates rigor, it creates, safety,
right?
All of these things, but he's saying, no, it should be that way. But instead of making it easier, just pay appropriately for the, very specific work that the clinical research, people out there do, which I agree with. I actually think I agree with more and more. Like, it shouldn't necessarily be easy. It is science at the end of the day.
Right.
So instead of making it easy, if you just pay us better, like we'll do it. it's a whole lot easier to do it if you're being compensated appropriately for all the junk you're having to do.
Well, and I think that's probably a big thing, right? Where it's like we're changing, we're gathering more data, we're getting more and more complex trials, and we're saying, well, no, when we ran a similar phase 3 trial that looked at this is what the budget that we did, without without compensating for the fact that now we're asking for X additional data for you to collect, and we're having to use additional new tools and resources, which probably help the scientific part of it, but you cannot pay me for the same thing because it is not apples to apples anymore.
Yeah, I tend to agree. Shout out, Jonathan. Thanks for commenting, man. Oversight of data through a trial can mean many things to many people. Some sponsors take a more literal approach than others. I mean, that is true. There's questions for me about things like, is it handled differently? A good example is like ePRO data. So, if a patient is filling out, I don't know, a daily headache diaries, if you're managing, I don't know, a migraine trial can get big. You could enroll 40, let's say 50 patients. If they're all filling out diaries every day and they're filling out a diary every time they have a migraine, that's a lot of data for a PI to be aware of. Now, I guess the question becomes, does the PI need to? What if there's something in there that would suggest there's an AE?
Right, like you have to, right? From like an oversight perspective.
Yeah, but unfortunately, there's really no good way across most of these ePRO platforms to really do that without being a gigantic pain. And again, maybe someday there are thresholds built in where like you only get notified if like something falls outside what's to be expected. But even then, what could be an AE is different from person to person. Having a migraine is not an AE, but if you have an increased amount of migraines than what you reported at baseline, well, that's an AE. That's going to be different for everybody.
Yeah.
So again, it starts to get kind of complex in managing those things. And I just see that getting worse now that, data is the, name of the game.
So I'm going to expose my ignorance here, but what is like the chain of ePRO for a patient reported outcome to like what oversight does the site have? And then how does it go, like who's like reviewing it? So, what I'm saying? Like patient submits this diary. What input does the site have before then it is reviewed by?
So I've seen this happen in different ways, and it probably depends on how these things are set up. So a lot of times I will say a lot of the ePRO data, we're not really, I'm not going to say we're not responsible for it, but it kind of lives in its own system.
Okay.
So if people are reporting, I had a migraine, I took a preventive medication or an abortive medication, that'll live like in the ePRO stuff. Now, I've worked with studies where every time they do that, we have to then go add that to their con meds. But you're not getting like notifications these things are happening. You just got to go check on them. I will say during the screening process is probably when coordinators are most like locked into what's going on an ePRO, because usually that's what's going to qualify a patient. Hey, you've got 30 days. You need to have at least 10 headache days, or you need to have at least 10 headache days. You need to have 7 migraines. So you're looking at that to see like, are they qualified?
Make sure
are they going to qualify? Are they going to qualify? Once they're done, you may not really be popping in on that quite so much. And again, I think it's handled differently by sponsors and depending on what's actually being collected in that ePRO. So yeah, some of it I feel like is probably not being really reviewed on a regular basis, because also for most ePRO systems, like, fuck it. Like Clario was a good example. Like getting into their reporting and looking was just, you might as well jump out the window. Like it's terrible to try to click through, figure out, get anything meaningful out of a report. I mean, I think we've seen some get better with dashboards that you can actually tell a little more about like what's going on at your site or with your patients. So I look forward to that, like more of that. But yeah, it's generally not nearly as much oversight or like looking into that data from the site side, at least in my experience.
It's interesting because, like, if I was a patient and I was on a clinical trial, I would assume any information that, like, great, I'm on a clinical trial, I have this e-diary, or that's I'm uploading my blood pressure through a cuff, whatever the fuck I'm doing. My assumption as a patient or participant would be like, yeah, the site's seeing this, they're reviewing it, they're going to make sure I'm good.
And see, it's more so that that's like one of those data pieces that like we're not collecting as a site, really. It's being collected by the sponsor directly or by the CRO directly, I guess. And I don't know enough to know like how that works, because it does seem a little bit counterintuitive based on everything else that happens at a site.
Well, but if I'm the like, you know what I'm saying? Like I get the flow of the data, but like the experience of, and like the expectations of the patient or the participant would be, in my mind, like, I'm getting everything else through the site. Why is the site? Of course, this is they're managing this my whole experience.
Well, and yeah, that's another conversation that I think is interesting, is that, you know, when I hand a tablet or a ePRO device like to a patient, I mean, they don't know that it's metadata's thing. They think it's like us, like it's coming from us. So like, which also sucks because a lot of the stuff is terrible. And so then we get the call for tech support or to walk people through the stuff. I'm like, dude, this isn't my software. It's not my hardware.
It's even an nth degree separation from there, because it's maybe a vendor platform that's being used by a sponsor that you're providing. And so who helps the patient? They're going to come to you. Well, then you're maybe you go to the CRA. Well, they're not an expert in the vendor either. Like, so it just becomes this like very unclear like ownership path and experience of like who's responsible for supporting this. I mean, I would, from the from the vendor perspective, that the vendor should be supporting this, right? Like, the challenge being is that then you have the sponsor configuring the vendor software in a specific way, potentially. So it's like this like weird who's responsible.
Yeah, but in my experience, they do not want patients calling vendors, or, you know, that's been my experience anyway.
Yeah. No, I think that's, but I think it's like who's responsible for it? Because it is like the site's not an expert in it. They're not really even involved.
You become one. You become one pretty quickly. Like, you find a way.
Do you charge for that?
I mean, there's not really any meaningful way to charge for that I've found. You can try. You can put in extra training.
Like, it seems like there needs to be like extra like training, like protocol level, like just a multiple of X number of systems you provide me, training I need to do on them, and like upkeep it. You know what I mean? Like, that seems like a pretty reasonable.
I sat down with a PI last Friday, and she was asking to like go through a budget, and we went through a budget together, a couple of them, and she was asking about like all these other things. She was like, we get paid for all that different stuff, right? And I was like, no, we don't. And the more I'm like explaining it, the more I'm like starting to realize, not that I didn't already know, but realize just how insane it is. Like, all the stuff we do, not really accounted for. And look, I get it. You can chalk it up to that's the, you know, cost of doing business or whatever. But, you know, ultimately, if sites are motivated or sites are incentivized to be really efficient, because we only get paid for the things we get paid for. We don't get, we can't bill hours. We can't do it. So if it does not result in or contribute directly to, you know, something patient facing or touching, like, we're not going to get paid for it. But then, you know, your other partner above you as CRO is not so motivated by the same pathway that you are.
Right.
So if I got a patient in front of me and I'm like, got to call a CRA, most of them are great, in fairness, but like, there's just a different level of
there's misaligned incentives, right?
Yeah. And so it does make it really challenging.
I think there should be overhaul of, like, it seems like protocol level budget items should be more robust then.
Well, and that's what you try to do, I guess, as a site, is you try to jack up all the other stuff so that you're all this unpaid time, you know, you're going to spend is at least attributable to maybe something else. It may not be like one-to-one. Like, yes, maybe I didn't get paid for the hours I've
but
spent
it's
on the
included
phone.
in
Yeah,
this.
right.
No, I get it.
And that's kind of the best you can do. And then you learn pretty quick after you're running a protocol, like, oh, no, this isn't close. Like, we either need to renegotiate or we're going to move on to this other
How
study.
often does that happen? Where as a site you renegotiate budgets? Or is it like you negotiate and you're locked in?
We try. I would say more often than not, like unless there's a compelling reason, like there's no reason for them to renegotiate with you.
Right, I was going to say, like, what would be the success of that? Because I'd be like, nah, you signed this. This is what we agreed to. Like, unless something substantially changes where it gives me the platform to say, like, hey, there's an amendment. We added and changed things.
There are moments where we've had leverage where, like, we were a really high enroller on a study that had like a 5% holdback.
Okay.
And we got up to whatever, a bunch of patients, and we were like, hey, will you guys please, like, that 5% is now like whatever, $100,000.
Large.
Like,
yeah.
Can we stop that? And they did. And they didn't have to. But, generally, unless you're either like really successful and you could do better with more, generally, I'm not saying, probably not going to see it happen.
Yeah.
Again, maybe that's other people's experiences have been different, but it's either like, hey, I can see the other side. Like, oh, well, you're already succeeding. Why would we give you more money? Like, you're succeeding on what you have. Or like, oh, you're not succeeding. Why would we throw more money at you because you're not getting anything accomplished?
I would bet it probably also has to do with like how other sites are doing too. Like if you're being successful and they're like, shit, to be successful, we need you to continue to be successful because our other sites are not.
Right.
So like, yeah, sure. We'll help you out versus like a lot of our other sites are super successful. You're saying you need more. Nah, we have enough sites who are doing it with this. There's no way.
Right.
And like how desperate they are probably or like how their sites are doing too.
Yes. And that's what you can, if you're looking at those new newsletters and everyone's at a 0 and you're above, or then you might be able to
push it around a little bit.
Yeah, we can do more. We can do more, but pay us a little bit more. We can help pick up the slack for some of these other sites.
Yeah.
All right. Well, we rolled right through that.
Didn't even touch the articles we pulled up.
I know. Cool.
Be like that.
Anything else exciting before we close out?
No, not particularly. I think we'll be back on Thursday.
I think so.
So far, seems like that's likely going to be the case.
Okay. Rock and roll. We'll see you guys on Thursday. Take it easy. Thanks for listening to Note to File. We're committed to continuing to bring you independent and unfiltered coverage of the clinical trial industry.
We want to talk about what you want to hear. So if you have something on your mind, hit us up at notetofilepodcast.com.